Hi, good morning, everyone, or good afternoon, depending where you're joining us, and welcome to today's webinar. Next slide, please. Again, welcome to our webinar for today, Mental Health Implications of Blindness and Vision Loss. This webinar is sponsored by the Northeastern Caribbean Mental Health Technology Transfer Center, or MHTTC. We're housed at Rutgers in the School of Health Professions and the Department of Psychiatric Rehabilitation and Counseling Profession. My name is Kathy Rivera. I'm the project coordinator here at the center, and I will be introducing our center and our webinar presenter for today. Next slide, please. The MHTTC is funded by SAMHSA, the Substance Abuse and Mental Health Services Administration, to enhance the capacity of the behavioral health workforce to deliver evidence-based and promising practices to individuals with mental health conditions. We also address a full continuum of services spanning mental illness prevention, treatment, and recovery supports. We offer training programs on evidence-based practices, wellness and recovery, school mental health, Hispanic and Latinx mental health education. And we also offer online education courses such as Wellness Matters, Illness Management and Recovery, Functional Thinking, and more. Next slide, please. Next slide, please. As a reminder, all of our services, our training events, our products and resources are available to you at no cost. Next slide, please. If you're interested in staying up to date with the events and products the Northeastern Caribbean MHTTC is providing, we ask you to please sign up to receive our email communications. You can do so by scanning the QR code that you see on your screen. And I will also provide a link to our email listserv in the chat box later in the webinar. Following this webinar, you'll be asked to complete a brief survey. We value this feedback and use it to improve our activities and inform our future activities. The surveys are also important because our continued funding is linked to their completion, so we thank you in advance for your participation. We also want to let you know that this webinar is being recorded and will be posted to our website within 7 days of this webinar broadcast. At the time of this presentation, Marian Delphine Rittman served as Acting Assistant Secretary for Mental Health and Substance Use at SAMHSA. The opinions expressed herein are the views of the speakers and do not reflect the official position of the Department of Health and Human Services, DHHS, or SAMHSA. No official support or endorsement of DHHS or SAMHSA for the opinions described in this presentation is intended or should be inferred. We encourage you to interact with our presenter during the webinar by using the chat feature. Please post any comments or questions you have in the chat, and I will collect your questions as we go and ask them of the presenter during the Q&A portion of the webinar and presentation. During the webinar, our presenter may pose questions to you, so please use the chat feature to answer them. Next slide, please. As a reminder, the MHTTC network is committed to using affirming, respectful, and recovery-oriented language in all activities. Next slide, please. And we also want to let you know that the new 3-digit dialing code for the Suicide and Crisis Lifeline is now available through 988 for people experiencing suicide, mental health, substance use crisis, and emotional distress, or people concerned about someone in crisis. Next slide, please. Now let's begin our webinar. We have with us Dr. Steven Silverstein with us today. Dr. Silverstein is a professor of psychiatry, neuroscience, and ophthalmology at the University of Rochester Medical Center and a member of the Center for Visual Science. He is also the George L. Engel Professor of Biopsychosocial Medicine, the Associate Chair for Research in Psychiatry, and the Director of the Center for Retina and Brain at the University of Rochester Medical Center. He is the former president of the Society for Research in Psychopathology and the former chair of the American Psychological Association's Task Force on Serious Mental Illness. Dr. Silverstein received his PhD in psychology from the State University of New York at Buffalo and completed his internship and fellowship in child and adolescent psychiatry at Cornell Medical College. His primary research interests are in visual system changes in people with or at risk for serious mental illness. He is also interested in the effects of vision loss on mental health and in interventions to assist people in coping with the emotional challenges associated with vision loss. Dr. Silverstein is the founder of the Eye to Eye Peer Support Program for Vision Loss, located within the Rutgers Department of Psychiatric Rehabilitation and Counseling Professions. Through Eye to Eye, individuals with vision loss receive training in peer support and provide critical information, emotional support, and mentorship at no charge to others experiencing difficulties adjusting to changes in their vision. Dr. Silverstein is currently on the scientific board of Prevent Blindness and was part of their work group that drafted recommendations for assessment and treatment of mental health issues in people experiencing vision loss. Again, I want to welcome everyone to our webinar, and I will turn it over to Dr. Silverstein.
Thank you, Kathy. All right, it's great to be here today, and thank you all for joining and participating in this. I'll be speaking today about mental health implications of blindness and vision loss. And let's see. Yes, first I just want to say I am not involved in any activities or with any organizations that pose any ethical or conflicts of interest with this presentation today. I have research funding from these sites listed here: the NIMH, Chernowitz Medical Research Foundation, Patrick P. Lee Foundation, and the Accelerating Medicines Partnership. But again, none of those directly have to deal with mental health issues in people with vision loss. So to get to what I'll be talking about today, I want to start out with an overview, just to kind of lay out the roadmap of what I'll be discussing, and then I'll get to each topic. So my understanding is that mainly I'm speaking here today to, of course, people interested in this topic, and many of the people are maybe mental health providers who don't have a background in this particular field. So I want to start off with just some basic facts and findings about blindness and vision loss, talk a little bit about the parts of the eye that are most related to eye diseases that affect vision, then common causes of vision loss, especially eye disease, just so we can speak the same language about what glaucoma is or macular degeneration, for example. And then we'll switch over more to the mental health side, really focusing first on the limits of typical available services for addressing mental health needs. There are many services available for people who are losing or have lost, or who even never had vision, but very few of those address mental health and wellness. So what are then some of the unmet mental health needs in people losing vision? Of course, another issue is that there is a lack of available services, so I will go over some of what is available and what some of the evidence is on the effectiveness of those. Then near the later part, I'll talk about recommendations either that I have or that have been made by other groups, such as Prevent Blindness. What should optimal wraparound care look like for people who are receiving vision loss services and who express an interest in receiving services for mental health? And what are resources that are available? There's actually quite a bit that is available for people, although again, not so much from a practitioner, but so I'll then conclude, and then we'll have a question and answer session at the end, where I'll hopefully be able to answer your questions, and we'll also have two of the people you'll see in video clips here who work at the Eye to Eye program that we heard about before, Doretha Smith and Larry Woodard, who have lived experience of vision loss, will be joining me for the question and answer portion. Okay, so just to start off with some basic facts around blindness and vision loss. The numbers are really staggering. More than 3.4 million Americans aged 40 years and older, so that doesn't even include everybody, are blind. And that's typically defined as having a visual acuity of 2200 or less. And the way to think of 2200 is what a typical person can see from 200 feet away, you can't see, let's say, from over 20 feet away, more than 20 feet away. You have to be very close up to see the same thing. So that's fairly impaired. Or another definition of blindness would be a visual field of 20 degrees or less. So that's meaning that you have essential vision, but very little peripheral vision. There's also a term that's sometimes used, visually impaired, which is having a visual acuity of 20/40 or less. There are other estimates, of course, of vision problems. Some of this work is the terms aren't that well defined, but some estimates, go up as high as 21 million Americans, which is, close to one, close a little under 1%. 80 million Americans have potentially blinding eye diseases, including diabetic retinopathy and macular degeneration. And some estimates are that these diseases will triple in prevalence over the next 30 to 50 years as the population continues to age and people live long. The major, but not only, causes of vision loss today are cataracts, age-related macular degeneration, diabetic retinopathy, and glaucoma. And I will be briefly covering these each in a minute or so. Some other things, though, besides just those global statistics, people who have vision loss, especially who acquire it, are more likely to experience than the typical person in the population: depression, diabetes, hearing impairment, stroke, problems with balance and falls, cognitive decline, and premature death, especially if there's no treatment. And so it's a very serious problem that affects much more than just how well the person sees. Of course, the decreased ability to see is also associated with problems with driving, reading, managing finances, traveling independently, which isn't to say that people can't do these things. There are people who have no vision who do some of these things, many of these things, I should say, fine, including, traveling to work and being fairly independent and using computers and using programs that read screens and things like this. But yeah, that's a large adjustment that many people have to make. I wanted to mention also the cost of vision loss is, again, quite astounding. This is actually an old estimate, although a good one. This is 17 years ago that it was $35 billion a year. This was based on direct costs and lost productivity of people, let's say, missing work and things like that. But the number now is really considered to be over $1 trillion. So it's a big problem for society, for individual people, and often for caretakers or partners of people. So to just clarify a little bit about what we're talking about with some of these eye diseases that people may present with who come to mental health clinics or who are working with eye care providers, but it's clear they need some mental health support. This here is kind of a drawing of the eye, different parts of the eye. And you can see there's several different parts of it. The eye communicates with the brain, of course, through the optic nerve, which is here. So this bundle of nerve fibers leaves the eye. The part of the eye that's the neural part that's most responsible for seeing is the retina, which is neural tissue at the back of the eye. And in terms of the retina itself, there's a few parts that are particularly important. One is the macula, and that's the part of the retina that's responsible for central vision, or your most clear vision, and also for color vision. And that gets damaged in a number of eye diseases, and that then will affect your ability to see what's right in front of you and to see things very clearly. Off here where the optic nerve leaves the retina, that area here, there are no photoreceptors or cells that really process what's coming in from outside. And so that's kind of off in the periphery. And I think everyone's probably heard of your blind spot, as it's called, where you really can't see anything. Your brain kind of fills in there. But this is a problem often when driving, that you can't see cars coming right up on the side behind you to some extent because that part of that visual field doesn't receive input. Anyway, problems that tend to occur around the optic nerve or near the optic nerve tend to affect more peripheral vision. And of course, there are many other structures in the eye, including here the anterior chamber, where pressure buildup can cause a glaucoma. So we'll get to that in a minute. But before we do, I just wanted to give a little bit more of a close-up of the retina because so many eye diseases affect this, this part of the eye. And here on the right is kind of a depiction of different parts or layers of the retina. Like the brain, the retina has a number of layers of blood vessels and different types of cells. If you've ever had psychology 101 in college, you may know that photoreceptors are the first cells that are responsive to light, darkness changes. And these are called the rods and the cones. The cones are responsible for color vision, primarily, and the rods responsible for seeing changes in contrast or brightness. From there, information goes to the next cell level, the bipolar cell level, where it's integrated across photoreceptors. And then from there, it goes to another neural layer called the ganglion cell layer, where there's further integration. And then it's the axons of those ganglion cells that form the nerve fibers that bundle together and leave the retina as the optic nerve. So we may be coming back to some of these terms like photoreceptors or ganglion cells later. This here is an image from a technique of retinal imaging called optical coherence tomography that sort of works like ultrasound. Ultrasound works with sound echoes to generate images like of a baby, and a pregnant mother. Optical coherence tomography works with reflections of light to generate images. So these aren't actual photographs, but images generated by light reflectance. And what I want to just point out here is this area of the retina that's responsible for the most sharpest vision and central vision, the macula. The center of that is called the fovea. You can see this little pit here. And that's because at that point in the retina, most of the cells, or many of the cells, are moved off to the side so that there can be as little interference as possible with light heading in towards the photoreceptors, which are several layers in. So you want to move as many of those ganglion cells and other cell types out of the way as possible. And off then again to the side, you have the optic disc where the optic nerve leaves the eye to go to the brain. And to the periphery of that, you have the nerve fiber layer, the NFL, or sometimes called retinal nerve fiber layer, or RNFL. And again, any damage in this area will seriously affect peripheral vision. So I wanted to now briefly cover some of the major eye diseases that are known to be associated with mental health issues. One being macular degeneration, which of course is degeneration of the neural cells in the macula, which again is that part of the eye responsible for central and color vision. I should mention that I keep saying central and color vision, and you might think, oh, well, isn't there color vision throughout, the whole visual field? And technically, no, because when you get away from the center of vision, it's mostly rods that are processing those parts of the visual field. And so in a way, seeing color vision throughout your visual field is sort of an illusion. But the only areas where our color is really being processed is in the center and the regions near the center. Anyway, there are two types of macular degeneration. Sometimes this is called, by the way, age-related macular degeneration because it typically occurs and starts in older people. There's a wet type of macular degeneration or neovascular that involves growth of new blood vessels under the macula that could leak and then cause all kinds of problems with vision there. And then a dry AMD, age-related macular degeneration, that involves degeneration of the retinal pigment epithelium, which is the layer underneath the photoreceptors that provides the pigments that allow you to see color and other nourishment to the photoreceptor cells. This causes scars in the fovea and a loss of central vision. So just to give an idea of what this would be like for someone who had it in the very early stages, you can see on the left here a normal picture of a boy. And underneath it is what's called an Amsler grid, which is something an optometrist or ophthalmologist might have someone look at when they go in for an eye exam. And what you want to see is a person looks at this and says they see, horizontal and vertical lines with no curvature, no distortion, no whatever. But early on in macular degeneration, as you're essentially losing some parts of your central vision, you get blurry vision and these distortions. And when someone would look at one of these grids, their perception of it would be like what's on the bottom right here. So that, and as they would report that to the optometrist, that would be a giveaway, that this changes that they see on the lamp exam that look like there's changes to the macula are now being reflected in actual changes in visual experience that a person is having. But like I said before, this would be considered fairly early on and mild. To give a more severe example, here's another photograph of two boys on the left, and then on the right is a kind of a recreation of what it looks like, what it would look like for somebody with more advanced AMD. And you can see here, there's a large area of the central visual field that you can't make out what's actually there. Now notice it's not just all dark or black or whatever, but you can't see clearly what's there. And so this is a very disabling disease, and the more it progresses, the larger the area that you can't see in occurs. Now, there's an inherited form of macular degeneration that does not begin in old age, but typically begins in childhood or adolescence, called Stargardt's disease. And in many ways, the process of what's happening is similar to macular degeneration, except it's just starting in younger people. But again, as you can see in this image, it's primarily the central area of vision where it starts, and then it just widens and gets larger and larger. And of course, people can lose all their vision from this over time, typically over many years. Now, another common visual problem is retinitis pigmentosa, sometimes called RP. RP, like Stargardt disease, is inherited. There are a number of different genes that can cause it. So there's technically a number of different types, but they all lead to the same kinds of problem, which is a breakdown in the rod and cone photoreceptors. But unlike macular degeneration, which starts with a loss of vision in the center, with retinitis pigmentosa, you're starting with rod dystrophy or rod degeneration. And so it's the peripheral vision that starts to go first, and the person will retain some central vision, but over time, that the amount of central more. And you can see that in the example on the right here. So that can become quite difficult to live with as it gets smaller and smaller. Another common cause of vision loss that's getting more and more common as more and more people have diabetes is diabetic retinopathy. And this is essentially a disorder of the vasculature or the blood vessels in the eye. So that as the blood glucose level overall is either too high or it's just not controlled well enough, you can get leakage in blood vessels. And so blood starts to basically go into the fluid in the eye, in the anterior or posterior chamber. And eventually scarring can occur as well. So it's less predictable than some of the other eye diseases in terms of where the person will start to have trouble seeing in their visual field, but it can cause very severe loss of vision. And this is just an example here of what it might look like for some people. And of course, it can be less severe than this, or it can be more severe than this. But it can take on kind of this patchy quality that grows over time. Another very common and serious eye disease is glaucoma. Traditionally, glaucoma has been seen as a disorder of pressure of the fluid within the eye so that it gets too high. And when it gets too high, the lens can be pushed back. So the pressure's more starts out in the fluid in the front of the eye. The lens gets pushed back, there's pressure in the back of the eye, and then since that's where the retina is, you can start to get all kinds of problems with blood vessels and damage to neural tissue, damage to the optic nerve. Glaucoma typically starts as a problem in peripheral vision, but again, as it progresses, it can crowd more and more into problems in central vision. I also wanted to say that there are multiple types of glaucoma, and it's not the case that in all people with glaucoma, there's elevated intraocular pressure. It does seem like lowering pressure always helps, even if it's not overly high. But more and more people are thinking of glaucoma as a neurodegenerative disease that's mainly found in the eye. Although interestingly, there are elevated rates of Alzheimer's disease and schizophrenia and some other severe psychiatric disorders in people with glaucoma. So it may be that the changes to the optic nerve and the degeneration happening in the eye is mirrored by what's happening in the brain. And just to review here, in glaucoma, the primary damage is to the optic nerve. And this is from that image I showed before, where the axons of the ganglion cells or the nerve fiber layer form the optic nerve and leave the eye here. But because of the pressure that can build up, this space here can widen and the nerve fiber layer on either side starts to deteriorate. And again, that's going to affect a lot of the output coming from your eye to the brain is going to be seriously compromised. Unlike the other things I've talked about so far, cataracts, which are a major challenge for vision, are not on the retina. So they're more in the front of the eye, over the lens and the cornea. And these, of course, some people are born with them. Many people develop them as they get older. They cause blurry vision, increased sensitivity to glare, so problems with driving at night, and eventually you can lose your vision from them if they're not removed. But I did want to mention that not every cause of visual impairment is a primary eye disease. Of course, you have to have something wrong with your eye to lose vision. But just as an example, and as shown here in this image, we now know that a history of abuse of any kind of drugs, really, prescription drugs, non-prescription drugs, legal drugs, is significantly associated with self-reported visual impairment. And things that many people do recreationally, like alcohol, cigarettes, inhalants, similar effects. And in statistical lingo, the odds ratios of having significant visual impairment, if you're a heavy, drug, cigarette, alcohol user, go from 1.2 to 2.1, which would mean, let's say, an odds ratio of 2 means that you are 2 times more likely to have visual impairment than someone who doesn't use those things. So 1.2 may not sound like a lot, but that still is like a 20% increase in risk of losing vision. And 2.1 is over double the chances of losing some significant vision. So really, there are many ways that vision loss can occur. Now, there are many services available, often through the state government. So in New Jersey, it's the Commission for the Blind and Visually Impaired. Every state has some type of commission like that. But in addition to those commissions, there are just many private practitioners and publicly available services. So starting with ophthalmology and optometry, you have ophthalmologists or medical doctors. Optometrists are not medical doctors, but they're specialized in eye care. But they usually don't or can't do things like eye surgery. But that's typically who you go to, one or the other, for diagnosis and then some medical treatment. So ophthalmologists can pretty much do anything in their offices. But for many people, of course, you don't just want a diagnosis or a medication or injection treatment. There's a lot that's needed to help people adapt and learn to live with whatever loss of vision they have. And so a major field here is vision rehabilitation, which includes low vision therapy, vision rehabilitation therapy, and orientation and mobility therapy. And these are technically different things, but so low vision therapy is really about using devices and assistive technology and environmental modification. So you're working with a therapist who's an expert to help you cope as the best possible and learn new techniques to basically learn new ways of doing the things you used to take for granted, basically. Vision rehabilitation therapy is primarily focused on living skills in the home and other environments. And this is really critical for people. And orientation and mobility therapy is a lot to do with indoor and outdoor travel skills, including using the white cane, electronic devices like GPS on a smartphone, for example, use of public transportation, use of a guide, for example, a seeing eye dog. If you're someone who gets a seeing eye dog, for example, you don't just get a dog and then, you're going all over the place. Quite a bit of training is involved in it. And of course, there are many vocational services to help people learn to do the kind of job they did or learn a new job. And for many people, they do have to learn to do something new, which is a major source of stress and adjustment. Now, those services work very well in terms of doing what they do to improve adaptation, to allow people to essentially regain skills and competencies that they may have lost due to loss of vision. But there are limits to what they can do, and they're not really meant to focus on wellness or to address mental health. And so this may be stating the obvious, but I want to say it anyway. Visual impairment can affect every aspect of life. Social status, right? If you have to change jobs or can't do certain things or can't do certain kinds of socialization anymore, or friends don't treat you the same way or want to be around you as much. I mean, these things happen. So social status, employment, finances and income, relationships, including intimate relationships, and can affect your behavior and your self-confidence. So things like confidence, your sense of identity, your sense of worthwhileness and personal value, all these things can be affected. And we really can't assume that just because somebody learns how to use a cane or gets a guide dog or learns how to use screen reader programs, for example, that they're going to have a full restoration of self-concept. That cannot be assumed, often isn't the case. So as I've said, very often the services that are typically offered and paid for, let's say by the state commissions, really have to do with learning practical solutions for everyday living, for getting around, for doing the job, et cetera. But they're not so much focused on mental health. Now, of course, some commissions, like the state of New Jersey, have programs associated with them, like the Aspire program groups, that can be effective. but a lot of state agencies don't offer those, and a lot of people don't take advantage of them. So the amount of services for wellness and mental health really are tiny compared to the amount of services that would be available for vocational and other types of adaptive recovery. And a simple way to think of this is that adjusting to blindness or any other major life change for that matter really involves three different components. And this is very oversimplified, but just to get us started, first of all, knowledge of the facts involved, knowing what eye condition you have and how it's best treated, what that involves, and knowing, that there are people out there who can help, and going to those people and learning these different skills and devices that you can use. Then there's behaviors involved. Are you doing these things to change your environment or change how you interact with your environment? And then, of course, there's the feelings that are involved. So two people who may have the same eye disease and know exactly what is going on with them and what they have available to them that they can do to get help. But one who's depressed and one isn't are going to have different outcomes, because the person who's depressed is much less likely to go on to access the services that could be helpful to them. This is a quote from a great book or guide, I'm not even sure how to describe it, by Tuttle and Tuttle, called Adjusting with Blindness, from 2004, that I highly recommend. Basically, adjusting with blindness is less than satisfactory unless the individual reaches the potential of self-acceptance and self-esteem as a person, first of all, and then as a person who happens to be blind. So in a way, this is simple, but it's also profound in terms of where you want the psychological recovery to go to in a person who's having a lot of distress because they're losing or have lost their vision. You really want to get them to a point of self-acceptance with high self-esteem, and they're learning to live with blindness as opposed to just thinking themselves as a blind person who's got all these, has internalized all the stigma associated with that and does not fully accept themselves as a person with worth. So, as may be obvious by now, many of the issues involve depression, at least initially in response to vision loss or a diagnosis of vision that involves vision loss. So I want to say some things about depression here. We know from many articles and studies now that an important factor limiting good outcomes, good psychological outcomes, but even good vision rehabilitation outcomes and good quality of life is untreated depression in people with blindness and visual impairment. That's what the B/VI stands for. It's a common abbreviation. So this picture here is just the title page of one such article, but there are quite a few out there. One quote from this paper by Renaud and Bedard is, considering the high prevalence rate of depression in this community, and they're talking about here older people with visual impairment, and its disabling effects on quality of life, QOL, interventions to prevent and treat depression are essential. Unfortunately, they, for the most part, are either lacking or ineffective, but we'll get to that in a few minutes. So just to say something about depression here, it's the most disabling mental illness in terms of the loss of work time and suicide rate and many other factors combined. And it's one of the major sources of disability worldwide. In addition, as I mentioned, it can act as an obstacle to good vision rehabilitation outcomes. We cite a study here by Harrells from 2005. Again, there are quite a few that show. So I do want to say here, this is not to say that everyone who has lost or is losing vision is depressed, and you'll see it's maybe a third of the people. So as a former commissioner of the Commission for the Blindness and Mental Health in New Jersey emphasized to me, we don't want to further stigmatize people who've lost vision by, now tagging a stigma of mental illness to them. But on the other hand, there are a significant number of people who have difficulty adjusting to their new situation, which involves vision loss. And there should be services available that are provided by people who are knowledgeable about what that's like to go through that. And so, again, it's something that needs to be screened for and recognized and treated, even though it's not going to be the case for everybody. Now, when people first access vision rehabilitation services, multiple studies, I cited 5 here, there are more, indicate that about 30% of the people will have some significant level of depression. The rates of depression in these studies typically vary from like 10% to like 45%. And as a general rule, the more severe the vision loss is and the faster it's occurred, the higher the rate of depression. That's not always the case because everybody comes to the situation with their own unique life history and personality. But in general, those are the findings. The higher rate of depression found in more severe cases of eye disease, where there's more loss of vision. This slide here is a picture from a paper I published a couple of years ago with colleagues from the University of Rochester. And we found here that as with the other studies, about 30% of this sample of people, and these were older people living in senior living facilities, not nursing facilities. So they were somewhat independent, but they were assisted type of facilities. About 30% had indicated on various questionnaires that they were likely to have significant problems with depression that should be treated. Interestingly, when we looked at what were the best predictors of depression in this sample, two factors came out. And one was, of course, loss of vision. But another one was loss of social support or lack of social support. And the combination of those also was important. And so again, you could have 2 people who are struggling with depression with the same eye condition and same loss of vision. But of those 2, the person who's essentially the loneliest and who has the least social support is much more likely to have lower quality of life and be more disabled in their life. Okay, so this is just saying how complicated the situation can be. Now, I did want to make a point I think is very important, especially given the still relative lack of services targeting mental health issues in people going through vision loss, which is that we've known about this problem for a long, long time. So this slide here, obviously, it's quite old. It's from a paper from 1970. And what it's showing is the percentage of people who had various different types of psychiatric problems, both when they were first seen, and that's the black line for each topic, and then 3 or more months after they were initially seen, which is the kind of diagonally hashed line. So you can see up at the top, initially, the rate of significant depression was over 80% in this particular project. And several months after the initial vision loss or diagnosis, it was still quite high, over 60%. Now, this isn't the same as major depressive disorder. It still can be very impairing and disabling. But this is just to give an idea of how much of a problem it is. And so you would think that then this who's working with someone who's starting to lose their vision or just got a diagnosis of a progressive disorder like macular degeneration, would be screening for and referring people for help, mental health counseling, if in fact the person indicated this level of depression. But again, that rarely happens. So I did want to point out way at the bottom of this graph, and it's in order of how common the problems are, the frequency, you can see that the percentage of people receiving psychiatric treatment in this same sample was about 10% maybe of the sample early on and about 5% 3 months later. So there's a discrepancy here between the number of people who are reporting that they feel depressed and anxious and crying. Just to go down the list here, they're socially withdrawn, they're having many physical complaints, they're angry, very high rates of these problems. But the rate of people getting psychiatric treatment is quite low. Now, we'd like to think that in 2023, where we are now, that rate would be much higher because there's less stigma around going to a mental health provider. But it's still too low even today. So I just want to say there's been quite a few years to have addressed this problem. And these problems aren't in the United States only. This table here is some data from just published actually, comparing rates of depression in different countries in people with various types of eye diseases. And you can see at the bottom 4 rows, Australia, England, the Netherlands, and India, you're still in that like 21 to 31% range. Interesting though, in the top 3 rows, Thailand, Bangladesh, and Brazil, the data were collected during the COVID-19 pandemic, and you can see how high the rates are there, 43%, 58%, and 54%. And one of the conclusions in this article is that not only are rates of depression higher in people who are blind or visually impaired as a rule, and maybe around a third of the people, but that when you add on some other stress, especially another stress that is potentially fatal and that further worsens social isolation, as it did really for everybody, then the rates of depression can go, much higher. And, in 2 of these countries, the rates are over 50%. So that's really a serious problem to keep in mind, especially during pandemic or some other type of stressful situation. Here, I'm just showing this title page from a paper that actually I wrote with a graduate student in 2020. That's essentially summarizes a lot of what I've already said here today, which is the data on the prevalence of depression in people with vision loss and blindness. Again, mainly people who are losing vision loss as an adult. It's a different situation for people who were born blind or who lost vision at a very early age. It's another situation entirely where you have a lifetime or at least adult mindset of how you live your life and solve your problems, and then you have to relearn all of that. And this paper also reviews a number of treatment options and how effective they are or not. So this will be in the slide that's available to everybody, and it's free online. It's an open access paper, and the link to it is on the slide. Now, I've been talking a lot about depression, but I do want to mention that depression is not the only mental health issue that is seen in people who are coping with vision loss. I mentioned briefly before about anger and anxiety, withdrawal. So this study, I just wanted to highlight here from 2015, showed that among people who had major depressive disorder, about half the people also had a history of 1 or more anxiety disorders. And that's just a general rule pretty much wherever you look at people with depression. And so the implication of this is that anxiety should also be carefully assessed in people with blindness or visual impairment, especially when there's a history of depression. Of course, people can have anxiety without depression, but when there is depression, it's a very common co-occurring symptom. And I also wanted to mention that these problems of people who are losing vision are not limited to elderly people. Sometimes that's a myth that some people still have. It's just not true. So studies that have been done looking at people, 19 and older, 20 and older, they still find the rate of depression to be about 3 times higher than what it is in adults who do not have vision loss. So these younger people who don't have all the other problems of aging, such as loss of significant others, or other types of chronic disease, it's still a problem. And in fact, what studies show here is that even after you statistically control for age, sex, race, ethnicity, marital status, whether you live alone or not, how educated you are, your income, whether you work, whether you have health insurance, how heavy or what's your body mass index, whether you smoke, drink, how healthy you are, all this stuff, how worried you are about your eyesight and other diseases. Even after you control for all of that, losing visual functioning is still associated with depression at a rate of about twice as much as would be the case if the person didn't have vision loss. And so that's really striking. There is something about losing vision and having to adjust to that major loss that is, for some people, many people, maybe about a third of people, something that really requires some mental health intervention. Okay, so far I've been talking about depression as if it's like one thing. You get depressed. But we actually know that, not everyone who's depressed feels the same way or thinks the same way or experiences it the same way. And so it's important to know about what are people saying who are adjusting to vision loss. Well, I mentioned depression and anxiety. Something that's, again, not all the time, but often a problem, at least early on, is lowered self-esteem, right? A lot of what you took for granted in terms of seeing the world, getting around in the world, doing things like just, putting on music, using a phone, whatever, you have to relearn. And so this can have major effects on self-esteem. Because you do lose so much of what you used to take for granted, there's often a development of an external locus of control where there's like a sense of that you cannot be an agent that determines the quality of your life anymore. It's now out of your hands and based on outside factors. And that, of course, that general stance towards the world tends to be associated with depression. Something else that's a problem is self-defeatist performance beliefs. Again, the idea that you're not going to succeed when you try something. Now, the fact is, anytime you have to learn something new or relearn something, you're not as good at it at the beginning as you are later with practice. So everybody knows that, I suppose, but the problem is when people give up because they assume they're going to not do well, and so they don't even try, or they don't try as hard as they could to get to a higher skill level. And that's a problem for a couple of reasons. One is it can, again, lead to depression, withdrawal, avoidance of things like vision rehabilitation that can be helpful, but it can also cause people in your life, significant others, to either be critical or to be overprotective, neither of which are good, for psychological functioning. Something that multiple studies indicate is that a major determinant of how someone feels about themselves after they lose vision is what their attitudes were about people who were blind or visually impaired before they lost their vision. So in other words, if you had very critical or stigmatizing attitudes towards blind people, felt sorry for them, that, they couldn't do anything, and how terrible it would be, etc., then you're more likely to have negative views of yourself and your future. And so that often needs to be a major focus of any type of therapy that goes on. You want to ask about that and work with it. Lack of acceptance of people's own sight loss. Of course, initially, many people are in denial, especially if they can still see some pretty well when they first get their diagnosis. But of course, it becomes more and more of a problem as you lose more and more vision and need to start finding new ways of doing things. And then if you're still in denial, your ability to function is going to go down and may lead to mental health issues. This slide here has a number of other aspects that have been looked at in studies of people who are blind. This is a project from the 1990s that looked at emotional reactions of people that were common when they lost their sight and then 2 years later. And so there are two things I want to highlight in this slide. First is the column on the left, the reactions people had. For example, there's nothing to get up for, nothing to look forward to. There's no longer meaning and purpose in life, no hope for the future, anger or bitterness about loss of sight, sadness, a sense that they wouldn't feel emotionally anymore because they're kind of in this numb state, lack of acceptance of what's happening, feeling embarrassed, especially in social situations, feeling alone and feeling like a second-class person. So that's that loss of self-esteem. This study concluded that the sense of hopelessness was probably the biggest problem in this population. So again, you can see there's a range of reactions. You don't want to just think, oh, people are depressed. There's specific issues that people are struggling with that are related to having to essentially relearn ways of doing things and in some ways be a different kind of person, or have to accept yourself as someone who does things differently. But on the right two columns, what this is showing is the number of people out of this sample of 104 people who improved 2 years later, so they had less severity of those symptoms or feelings, or who declined and who felt, worse. And many people declined; they felt even worse. Now, for the most part, these were people who were not in any kind of mental health treatment. But what this is saying is that if there's not intervention and no one to talk to about these things, people are unlikely to just get better on their own. And so again, whether someone just got their diagnosis or just lost their vision, or even 2 years later, there's quite a lot of work to do. Now, something I wanted to mention here is I've been talking about depression being related to vision loss as if the loss of vision or the knowledge that you will be losing more and more vision itself is causing the depression. Now, clinically, it does seem like that in a lot of people. But what I want to highlight here in the next slide is that there are other factors that can also worsen the degree of distress that somebody's in. And one of these is something called Charles Bonnet syndrome, sometimes called visual release hallucinations. And basically what this is, I think everyone's heard of sensory deprivation. If you go in a sensory deprivation tank and you're not having any visual input or auditory input into your ears, your brain will create its own activity. So you'll start hallucinating, hear voices, you'll see things, images, or visions. Now, if you've got an eye disease, for example, like retinal disease like AMD, you are essentially causing sensory deprivation, not a total deprivation like you go into a sensory deprivation tank with blindfold on. But it can get to that, but certainly you're losing big areas of your visual field. So what often happens in people, about 30% or so of people who lose significant amount of vision, is that at least for some time, they will experience these hallucinations. Now, what this, you're not going crazy and you're not, developing schizophrenia, say, but this is just it's like a trick your brain is playing on you because your brain's not used to not getting visual input. And so now there's less of it and it's making its own. And often this goes away on its own. And certainly it can be very helpful for people's anxiety when they learn what is really going on and they don't think they're developing a whole nother psychotic disorder. But on the other hand, sometimes the hallucinations can be quite distressing to people. And so it's something to look out for. So not everybody wants to talk about it, so it's helpful to ask about it. I think what I'm going to try to do here is to show a video, which I cannot show just by clicking on this link. So Kathy, if you could stop the recording, I'm going to show this YouTube. Thank you, Kathy, for restarting that. So that's just one example of something that many people have to deal with that is kind of a secondary aspect of their eye condition. And I wanted to mention one other one here, but these are not the only ones. You know, you also have to watch out for things like substance use, for example. But just in terms of treatment, I wanted to mention that for conditions like diabetic retinopathy, where there are blood vessels growing in the eye to compensate for ones that are being destroyed by the disease, but the new ones that are growing are often fragile and they leak. So what the treatment often is injections into the eye of chemicals that can stop the growth of new blood vessels, or so-called anti-VEGF injections. I don't think anybody would ever look forward to getting this. Of course, it can be helpful to slowing down progression. So these do help a lot of people, but many people also get quite anxious before they have to go in for treatment. And so this image here is just a study that looked at over 130 people with AMD, with the neovascular type, so they would need these injections. Over a third of the people needed some type of support to get to and from the appointment. And about a third of the people reported in the week before going for these injections. And again, many of these people got 9 or more a year. About a third of the people reported to be stressed, and about 15% struggled with sleep, which again is only going to make things worse. So the point of this is just to say that you don't want to just think about what someone's eye disease is, but also what the treatments are, how getting the treatment affects their life, what other secondary effects they're getting, such as, you know, these Charles Bonnet hallucinations, etc. There's quite a lot to think about. And you know, I should have said this before, but most, over half the people reported these injections as uncomfortable or painful. But there are other things that make the situation harder too for people. And one of them is that often the eye care providers don't ask about mental health issues. Many people say that they, in a way, had to develop a new sense of identity for themselves as a person who's living with blindness or coping, adjusting to it. And this can mean very different things to different people. As I mentioned before, if the pre-blindness attitudes towards other blind people were negative, depression is more likely to be there, and it becomes more challenging to get somebody to begin to essentially psychologically recover from the depression. There's this quote here from 1958, a really great book about by a psychiatrist working with blind consumers, that the psychological problems of blindness invariably have at their core the attitude of the patient towards his affliction. So again, this has been known for quite a long time. And many things are difficult, at least at first. So, for example, if things break, you need a lot of practice to relearn how to do things around the house and other places. Many people are angry, things they can't do, or being with other people and they're talking about things that they see. And many people don't have the kind of balance they used to, so running becomes, for example, much more difficult. People become aware of stigma from other people. Many people report that it's harder to be spontaneous in social interactions. People can have concerns about attractiveness and sexuality. You know, is my partner still going to be attracted to me now that I'm blind and using a cane, etc.? Again, none of these are inevitable, but they're common. I wanted to show this quote here. This is from an article that was in 2018. I'm just going to read it. And I think it's obvious what the problem is. So this person, actually not the person writing the article, but she was describing something someone else said here. I've always been an active member of my church. Recently, while attending a shower for a member, I went to bite into a cupcake topped with a wonderful fluffy icing. I got the icing on my face. I went to pick up my napkin, and before I could wipe the icing away, someone pushed my head back and proceeded to wipe my face. I didn't know what to say or do, but I knew I felt humiliated. I didn't want to stop participating, but what do I do with the feelings and how do I address the situation? So that's, a bad situation there. And, with feelings of humiliation or shame, and it's in public. But these things happen. And again, if you're working with people who have gone through or lost vision, these are the kinds of situations that can come up. And it's important to ask about them and to be prepared to work with someone around the feelings that come up. So I think at this point, I've done enough talking for a while, and I'd like to show these video clips from two people who work at the Eye to Eye program and at Rutgers, and who have been really excellent advocates for people with vision loss. And the next people in these next two videos will be people who will be joining me in the question and answer session. So the first one is from Doretha Smith from Rutgers, and then Larry Woodard, who's also at Eye to Eye. And so you'll be hearing about some of what their journey has been like and what some of the issues were that they faced. So now I'm going to play the video from Doretha Smith.
Hi, my name is Doretha, and just for a few minutes, I'd like to share with you my vision loss and how it impacted me in several spectrums of my life. I was diagnosed with retinitis pigmentosus, sometimes called RP, which is severe eye disease impacting or affecting the retina. It's a genetic eye disease, and it impacted me in several ways. I was originally diagnosed with a disease in my eye around the age of 12 or 13, and then they eventually diagnosed me with RP as I went further in my teenage years. Though I was diagnosed with a disease, but it was deemed not bad enough to receive any help. So I didn't know what to do. I didn't know where to go. I understand my parents didn't know what to do at this point. I even felt ashamed of myself. I kept people out because it was just hard for me to be able to socialize because I was worried about what people would say. I had that fear of how people would react or respond to me. And so throughout my life, through those teenage years or as a young adult, I faked it. I learned how to move forward, but not getting the proper help or connection that I need. And not only that, as my eye progressed from one point to the next, as a ship from one point to the next, also how my emotion also was impacted is because the unpredictability of this eye disease, means that it fluctuates here and there. At times, it may appear normal as normal could be with the vision loss. Then at times, it was seen as though my vision loss was going to go completely. Sometimes I would wake up or things would just seem like it just go black. But then in a hot second, it bounced back. That was a very scary and very overwhelming feeling. Just feeling that. So that made it very difficult for me to cope and to adjust. My emotions was everywhere. My feelings here and there. My thoughts was everywhere as well. I didn't know what, and that was even more. So I didn't let people in because I was scared. I was angry. I was frustrated. Didn't know what to do. Relationship also was impacted because I didn't want to hear the stereotype. People treat me a certain way because they made assumptions about vision loss. And sometimes I gave into the stigma. But there came a point in my life when I started to learn how to cope in the right manner, meaning that I connect with people, with organizations, I connect with the community, I connect with support groups. I could even allow my family to connect in more with me and gave them a better understanding of my vision loss, and they were able to support me in a better way, in a better manner. And most of all, I connected with my faith, my trust in God, who got me through and who's still getting me through today with adjusting to my vision loss in the process that it all entails.
Okay, thank you,
I'm
Aretha, and we'll be again. She'll be joining me and Larry Woodard at the end for the question and answer. So I'd now like to play this video clip that was created with Larry Woodard speaking, and hear from him. And again, you'll hear just about some of the range of issues that people deal with, and what it was like for them. So here's Larry.
My name is Larry Woodard, and I'd like to talk just a little bit about my vision loss. My vision loss occurred about 10 years ago. I was diagnosed with glaucoma about 5 years prior to that. But until that time, I had not lost my vision. In fact, my vision was very good. But then all of a sudden, it sort of went downhill. And at that time, I was not aware of the true impact it can have on one's life until that time, because of the fact that no one really plans for losing their vision. You don't have a plan A, you don't have a plan B, you don't have a plan C or anything like that. The only plan that you have is working in your career, working towards retirement, but you don't plan for vision loss. But there were three things that I was getting with immediately. The first one was that here I am, I was experiencing my vision later on in life, and had to understand and be faced with the impact of that and the adjustment process, and also the loss of identity. And I say loss of identity because now you no longer see yourself as you saw yourself earlier. And those that are around you no longer see yourself the same way. The perception of you have changed. And that's something that's very important, no matter who you are. For me, it was traveling. I traveled a great deal in my job. I interacted with a lot of people. But all of those types of things, is your identity is sort of tied in with those things. And then when you're faced with that no longer, you may be doing those things, but you are seeing differently, you see yourself differently. It can bring about certain psychological factors that can affect you, such as, your perceived control that you think you have, your self-esteem, sense of cohesion, and trust within yourself, able to do certain things, and trusting in others too. So acceptance of loss is a very key component of it. And I say acceptance of loss is a process of value changes. And the absence of the ability to accept oneself unconditionally can lead to a variety of emotional difficulties, such as anger and depression. The second thing I was confronted with was the impact of vision loss among myself as being an older adult, and complicating conditions that could either contribute or increase the loss of independence and adjustment. And it can be very frustrating for individuals that are older. And also, as an older adult, you're talking about learning something new. Here it is, all the things that you learned before. As an older adult, now you're having to relearn all those things again. We know that sometimes it's a little bit slower. It can be a little bit more tough, a little bit more frustrating. And we know that American adults aged 40 years and older are at greater risk of eye disease. So combining that with some other type of chronic condition, those combinations can impede the process of adjusting to it. And then the third thing was the combination of disability. I've had hard of hearing ever since I was a young person, you know, since I was 18 and up. But during that time, I was okay because of the fact that I had my vision. When I'm around a crowd of individuals, I no longer can understand distinctly what one may be saying. And certainly I can't read your will. Even though I have hearing aids, I can make out certain things. I can make out certain things and I deal with it that way. But for an individual that is completely deafblind, their world is narrowed even more so. And sometimes the information that they have to rely on is information that are given to them, not information that they're able to visually and auditorily able to hear themselves. I would encourage individuals to learn as much as they can about the population of older adults and visual impaired. So ask questions. I encourage those that are in the mental health field, human services field, to be inquisitive, to ask questions, to try to understand and learn more. So that's my view. Thank you. My name is Larry Woodard.
Okay. So yeah, I found those videos really helpful. I thank Larry Woodard and Doretha Smith, and look forward to hearing more from them later on. What I'd like to shift to now is this idea of not just treating depression or treating anxiety, but different stages of psychological adjustment to loss of sight. There's not that much written about this, but there's some, and I found it very helpful when I was first working in this field. I mentioned before this book from 1958, A Psychiatrist Who Works with Blindness by Cholden. That's a very early work in this field. And he talked about this initial stage of depersonalization, kind of denial or feeling disconnected almost, or emotionally numb, when learning or seeing that you now are losing vision, to a second stage of depression and kind of fully experiencing all of the loss or the amount of recovery that's going to be needed, and then a third stage of recovery. So that's kind of a simple distinction of thinking like where somebody may be, who, let's say, comes into your office for treatment. You want to have a sense of where they are in that sequence. Well, more recently, this has been elaborated quite a bit. So I mentioned this book by Tuttle and Tuttle before. I realized I said the name wrong. I said it was Adjusting with Blindness. It's actually Self-Esteem and Adjusting with Blindness. And they make a point in their book that it's adjusting with blindness, not to blindness. So again, it's something that you as a person of worth are learning to live with. They talked about an initial set of stages that had to do with the initial reaction to losing vision. So initially there's some change, you develop an eye disease. There's a stage of shock and denial, which many people go through. The next stage they call mourning and withdrawal. Again, withdrawal, this is quite common in people. And then ultimately followed by succumbing and depression, which is kind of like the lowest point in the recovery process. And then the next set of stages are really what they term the rebuilding process. So reassessment and reaffirmation. That's when you start to get some energy back and changes to your self-esteem. So you start to see that you can have a life, it can be a good life. You're having to do things differently, but you are starting to see yourself again as a worthwhile person. Coping and mobilization, again, very important. Learning a lot of these new skills. Self-acceptance and self-esteem would then be the final stage. And that's ultimately why we want to get people to. Now, like any sequence like this, nobody ever goes through this one step into the next, like a straight arrow. So, each person could be in one stage and then be in a different stage. If you go back, it's helpful. It's helpful for me. It's helpful for a lot of practitioners, just in terms of thinking about where somebody is when you first meet them. And of course, when you're working with them for a while, then where are they then? Or where do they have to go? And so I really highly recommend that book, and to think in terms of these types of stages. I just wanted to highlight this paper from 2012 on emotional support and counseling for people with visual impairment, which made the point that therapeutic input for the visually impaired client group may need to target both well-being, such as feelings about oneself in the future, and problems like depression, anxiety, physical health, and trauma. So again, it seems almost too obvious to need to be said, but it is important. You don't just want to, give an antidepressant and assume you're done, right? Because the feelings about yourself in the future, about your self-worth, and accepting yourself, those are what the ultimate goal of the work should be, not just reducing that depression inventory score, for example, having somebody learn how to use a screen reader. I also wanted to mention that often people with various kinds of what are called disabilities often experience microaggressions from other people who don't have those same problems. And this particular paper here from 2018 isn't specifically about people with vision loss, but we know that this does happen in people with vision loss. And that the more you're exposed to people in small ways, kind of making you feel like you're not okay, let's say, or deficient in some way, the worse your mental health is likely to be. And it's especially true in the cases where the problem someone has is visible to others, as is typically the case in people with vision loss. And so that will affect kind of where someone may be in those stages of recovery. So can dealing with stigmatization that many people have. People with blindness or low vision frequently encounter stigmatization in their daily lives, including from their friends and family members. And this has been shown to lead to a number of negative outcomes, including not participating in rehabilitation programs, which is really something that's going to have a major effect on a person's ability to function in the world. It leads to social withdrawal, reduced sense of mastery, more anger, feeling uncomfortable in situations with other people, and shame and embarrassment. So again, I'm highlighting these things to say, if you're a mental health practitioner working with people who are losing or have lost vision, you not only have to deal with where they are in the process and the feelings of depression, anxiety, or low self-esteem, but there are likely to be ongoing experiences in the person's life of microaggressions and stigmatization that are going to continually continually be happening and need to be worked through and discussed. Okay, I did want to mention very quickly here, this was from another Breilmannen article, actually one I had mentioned before, but I found this very interesting. The quote here is, this is by someone who's a National Federation of the Blind member. She was talking about what happens at convention meetings. My predominant reaction to vision loss has been surprise. Surprise at how much I used my vision, surprise at the grief I had in losing it, and surprise at how reluctant I have been to talk about it in the NFB, where everyone seems to have adjusted to it without the pain or the difficulty that I have experienced. And then she goes on to say, it's just as safe to talk about our struggles as it is our successes. And we are not lesser federationists because sometimes we heard about the things we've lost. I wanted to mention this because I'm personally a member of the National Federation of the Blind, and I really like a lot of their philosophy. But it certainly is about succeeding and advocacy to get accommodations may and fighting for, which people should fight for. The other side of it can be that some people don't feel like there's a place to talk about the struggles that they're having. And so again, that's another reason why having a safe space like a therapist or a counselor can be very helpful. I did want to show this though, on the other hand, the benefits of role models. Now this is a quote also from the Braille Monitor by an adult, but talking about when they were a child, how learning about the NFB and going to conventions showed me tons of independent blind people who I could look up to, real life superheroes that I could aspire to be like. And I just want to point this out as well, and why peer support can be so important. It's really critical to know if you're going through this, that other people have gone through it and to learn from other people. Okay, so I've talked a lot about a big problem, which is prevalence of mental health issues and what those are, and people who are losing or lost vision. I did want to say there's another problem though, which is that there's not sufficient counseling and emotional support available for people who want it. It's really quite striking. This is a quote from a paper from 2014. The literature is silent regarding proper approaches to diagnosing and managing suicidality among patients with visual impairment, especially age-related macular degeneration. Now, of course, most people who get depressed are not suicidal, but many are. And of course, it's very common in older people. And you have to keep in mind, anyone with age-related macular degeneration is not only dealing with that, but also dealing with all the other issues associated with aging, where depression tends to be highly prevalent anyway. So now I'd like to show our last video. This is by Natalie Watkins for another personal perspective that I found very interesting and helpful. So,
I'm Natalie Watkins, and I've lived everywhere on the sighted blind spectrum. I think the importance of good mental health care in the vision loss journey cannot be overemphasized. I know for me, it would have been really pivotal to have that level of support on my journey. Firstly, there were so many practical adaptations to make, and they were adaptations that the public in general just doesn't understand, such as transitioning from one professional career to another, losing a driver's license, and learning all of the creative problem-solving techniques it takes to just manage a life in a city that is a car culture without being able to drive. Relationships were impacted, learning to set boundaries around accepting help and teaching people how best to be helpful, self-worth and identity issues during major life transitions. All of these various transitions, changes would have been greatly smoothed over if a professional had been on my team, helping me stay accountable to the best version of myself and celebrating those small victories as I met my goals and basically developed more resilience. Another issue that I really did not process fully and it came out sideways was the level of grief. There were so many cumulative losses over the years, and there was really no space in my busy life in which to grieve those losses. Having a sacred and safe space with a mental health provider in which to grieve would have been so beneficial and would have saved a lot of pain and heartache. I think mental health practitioners really need to be aware of their biases, stereotypes, and assumptions around vision loss. I had an experience with a mental health practitioner in which she told me if she were me, she'd jump off the building. I know this was her attempt to empathize and be real, and I appreciate this, but it wasn't supportive or productive or at all helpful. And I just left feeling really deflated and like the life that I envisioned for myself simply wasn't possible.
there are so many blinded individuals who have taught me along the way that it's not only possible to survive vision loss, and I think that needs to be at the core of a belief system of any practitioner who chooses to work with those who are blind or have low vision. So in summary, I would like to say dealing with the practical adaptation to vision loss, celebrating those small victories, and holding clients accountable would be incredibly beneficial, providing that sacred and safe space to process grief, and really being conscientious as to not project biases onto clients would be the main takeaways from my experiences on my vision loss journey. Thank you for listening and for having an interest in working with those who are blind and have low vision. I'm Natalie.
Okay, well, that was very really interesting to hear that. I guess you never think that comments by mental health providers may be bad for people's mental health, but clearly that can happen. So I wanted to say, I've been saying all along that about a third of the people who are losing significant vision will report or have problems with depression. And it's about 1/3 as well that believe they need and could use emotional help and counseling, just like we just heard from Natalie. Often, unfortunately, people who want the help can't find the help. And the literature is full of quotes like this, like we just heard from Natalie, like, if I had someone to talk with about my loss of sight, I would have appreciated psychological help to discuss emotional problems such as anger and grief. And this was a few years after the initial vision loss. Right now, I would still like and appreciate this help. And about a quarter of people in research have said that they don't feel able to talk to the people in their everyday life about these concerns. Now, I wanted to say a few words here about primary barriers to addressing mental health needs. These points come from the organization Prevent Blindness and from an issue brief that was just released last week on vision loss and mental health, key takeaways from an interprofessional task force. This whole topic is going to be reviewed in detail at the Prevent Blindness Summit, which is happening on July 12th and 13th. And you can register for free on their website, preventblindness.org. So I wanted to mention that here. But in terms of just a few specific points, there's really limited awareness of mental health needs among eye care providers. And that's something that should not be that difficult to change. Sometimes eye care providers don't really want to deal with it because it can make them feel like a failure. So it's a little more complicated than it may seem. It's not just providing information. It's helping people think differently about how they're supposed to practice. Not that the ophthalmologists have to do psychotherapy, but at least asking about it, having screening in the office and referring people, which that assumes that there's therapists to refer people to, which is another issue. Of course, there's limited time to address mental health needs and eye clinic appointments, a major shortage of trained mental health providers with knowledge and experience regarding vision loss. I still can't believe what a shortage there is. Then, of course, there's stigma, including from potential providers. And sometimes resistance to referring patients from eye clinics to rehabs, like vision rehab therapists, because it seems like giving up in a way. And so these are just some of the main barriers. I did want to mention also that there are a number of projects now that have been done to do looking at, problem-solving therapies, especially for people with blindness or visual impairment, but most of them don't show a lot of effectiveness for mental health. They do help people problem solve better around their day-to-day life, but they're generally short and they, 8 sessions, say, and they don't tend to reduce depression or anxiety. These are just some images of some of these very good studies by very good vision experts and scientists. And they're very clear that the short-term problem-solving therapies are not something that seems to help mental health that much. I mentioned social support before. This was again in that COVID-19 article showing much higher rates of depression during COVID. And again, social support, having bad social support, especially including perceived overprotection and less positive support, related to more depression among people with visual impairment during the pandemic. Okay, now only have a few minutes left and I want to get to the question and answers. So I just want to finish up with some recommendations. I'm not going to go into these in detail because everyone will have access to them on the slides that'll be available to everybody. And then the resources. But in terms of just overall recommendations, people with vision loss, I hope I've made this clear by now, people with vision loss and significant mental health issues, which is averaging around 30% in many different projects, but it can go higher, should have available to them support, counseling, or therapy with counselors who are specifically trained to work with people who are recovering both internally, psychologically, and externally in terms of practical living skills from losing their sight, right? It really helps to have a therapist who understands what's going on. Counseling, ideally, according to some people, should be a precursor to rehabilitation because it'll increase the likelihood of going to rehabilitation and of benefiting from it. So that's an opinion based on experience. It's have not been studied extensively, but it intuitively makes sense to me. Services for many people, again, not all, many people with blindness or low vision would be, quote, enriched by concern with meeting internal needs and concerns, such as self-esteem and self-acceptance. That's important to add to the overall intervention, so it's not totally focused on just coping and achieving, learning or relearning skills. People with lived experience of vision loss may be especially useful in providing these services. I've seen that firsthand with the Eye to Eye program in New Jersey and the Aspire groups in New Jersey. It's just critical. And any good system meant to provide comprehensive care for people with vision loss should be employing peers. So this next set of points comes from the Prevent Blindness Task Force again. Again, just to reiterate that change or loss of identity, self-esteem is so important. This is, if you're a mental health provider, this is something where even if people don't come out and tell you, oh, I'm having to rebuild my identity, it's something you should, have your antenna up for and be thinking about interpreting what people are saying in this context. Loss of independence is a big problem for many people. Often it's a cause of depression and anxiety. And again, there are many resources out there, not so much in the mental health community, but in the vision loss services world that can help people regain independence and self-efficacy, especially if you're getting support around self-esteem. Often keep in mind, again, there's a very high rate of depression and anxiety when people first learn about a vision loss diagnosis. That often is not the time to do the most intensive psychoeducation because people just are not emotionally or cognitively in the state where they can process everything. But eventually, of course, you do have to give people the information they need. And again, keeping in mind that someone who's losing vision or who just lost it, who's 50 years old, it's very different than someone who was born blind or who lost vision as a 4-year-old. And, keeping in mind the stage of life that somebody's in is critical. I'm actually going to just skip this one slide to save time, and we're just about at the end here. Just to say that Prevent Blindness task force is really come up with some good recommendations for training eye care and mental health and primary care providers. And again, to ensure that there's comprehensive care for people with vision loss who are also dealing with mental health or coping challenges. They ultimately want to move to an integrated eye care model. I encourage anyone who's interested in this field to avail themselves of the many resources that are out there. They're not easy to find, I will say that. it's not like I ever found one place that listed all of these things. But I will just want to mention a few here, but again, these will all be available to slides that you'll have access to. Pebble, which has a number of online courses and programs. There are several of these really good podcasts, including Living Blind, the Blind Guy Travels podcast. The video of B before with Charles Bonnet syndrome comes from the RNIB, the Royal National Institute for the Blind in the UK. They have an excellent podcast that cover all kinds of things, about learning to use the cane, the sexuality after vision loss, and just a whole range of topics. And they've been going on for years. There are many others. We mentioned before, Prevent Blindness. There are some excellent books out there on first-person accounts of losing vision and coping with it. And to just list a few more really good websites. And I did want to put a special mention in for Eye to Eye, the Eye to Eye program, which is now run by Alicia Lukashko. At Rutgers, this is a peer-supported program. It's phone line based. It's great to get information or emotional support. It can be ongoing, not just one time. This program's been around for about 5 years now. It continues to grow. Alicia and I wrote a paper, which is an image of here, an old picture of me, on just the challenges of trying to develop a program like this within essentially what's a community mental health center that is associated with Rutgers University. Quite a few challenges. It's not easy to set up a program like this, but the fact that it's grown is a real testament to the staff who work at it, some amazing people, and to the need that there is in the country. This started out just in New Jersey, and now people are calling in from all over the country. So just to summarize, this is my last slide. Conditions that affect vision can have short and long-term effects on mental health. A significant proportion of people with blindness or vision loss express a desire for assistance with mental health needs. Of course, many people aren't asked if they have a desire by eye care professionals, and so that's something that's a major obstacle. But even when people do express an interest, often no one knows where to refer them. There are very few therapists who specialize in this with this population, very few professional mental health programs that specialize in this type of work. Rehabilitative services are useful and often very well known by people who've lost vision, but they cannot be counted on to improve emotional well-being. They can, but it can't be assumed that it will all the time in all cases. There are a number of therapies that have been developed, but they tend to be short-term and have not really had an impact on mental health. So much more needs to be done to develop interventions that are to improve mental health for this population. I mentioned before, I'm a strong believer in peer support services. I've seen them work. I don't think it's been studied in a research type of way with like large samples, but and partly because there hasn't been enough of that work done, even to study. But that's something that does need to be done. But in the meantime, it's a very promising practice. Clinicians experience and are trained in working with people going through the stages of adjusting to living with blindness are needed. I don't know any training program or even any CE program that deals with this, but that really should change. And last but not least, I agree with Prevent Blindness that integrated eye care and mental health care is realistic and needed. And hopefully that can happen one day. So I'd like to thank you for listening. I went a little bit over. What I'd like to do now is move to question and answers and bring on Doretha Smith, who you heard from before, and Larry Woodard, who you heard from before, and take any questions that you may have put in through the chat function.
Thank you so much, Steve, for that, Dr. Silverstein, for that wonderful presentation and all the very useful information that you shared. I just want to take some time to ask everyone to add their questions in the Q&A if you have any. We have a few that have come in And Larry Woodard and Jaretha Smith, I have one that is directed towards both of you. And that question is, what are some best practices to avoid microaggressions, including infantilizing language when the other person's best intention is to help, but it may be received as disempowering language or help? So either Larry or Jaretha or both of you, if you could respond to that. Thank you.
Yes,
Do you
I
hear
will.
me? Go ahead, Larry.
Oh, go ahead, Aretha.
No, I was just going to say, one thing I know, I as a person dealing with this, it's important to educate, though, because I can relate to it just with my loved ones who may not mean anything by it's harmful, but don't know exactly how to say it, because we had to think about they are adjusting as well. And sometimes they may not understand the right way. So sometimes, as I said, you got to educate, we got to educate ourselves, educate people, and let them know how to relate to someone that's blind, vision impaired. And, some people just don't know, mean well and really don't know. So I think a key thing, one of the things is to educate people.
Thank you, Jaretha. Larry, would you like to respond to that or add anything?
Yes, I agree with what Aretha said. Also, I would say in regards to microaggression and language, I think sometimes people, as the question stated, they mean well, but sometimes certain things as saying, well, I know that you can see better, or something, they may say it jokingly, such as, see, I know you saw that. Because people's vision is not the same, and sometimes it changes too. So sometimes people that may have whatever, depending on their disease and visual impairment, they may see something on the floor at one particular time, and they may not be able to see something that's right in front of them. It does not mean that they could see any better. It just means that at that particular time, depending on what the lighting may be, or like I said, their disease may be, that they may be able to see that particular thing at that particular time. So sometimes, it may make the person feel like they are not being truthful or being lying or something of that nature, when they're really not. They really can't see certain things. So I think that's one of the things that sometimes you're confronted with. I'm not confronted with that, but I've heard many other people have had that situation. And I also think the other thing is, when someone means well to ask for help, asking to help someone, and if sometimes the person may say, no, I'm okay. And I would say to those that are speaking to that person, remember that person may be okay. They may not need your assistance at that particular time. And it may sometimes impede their independence, because they may have had some O&M training, orientation mobility training, and they want to put that into practice. And so thinking that that person may need your assistance at all times may not be the best approach at all times. So that's what I would say.
Thank you, Larry. There's a question now for Dr. Silverstein around, so what is the prevalence of vision loss due to psychosomatic epidemiology?
Yeah, I actually don't know the answer to that question. Certainly people can lose vision from psychological reasons, and it's rare. I don't know the prevalence of it though.
There's one more. What would be the differential diagnosis of dementia and Charles Bonnet syndrome?
Yeah, that's another good question. Of course, in dementia, you're going to see cognitive decline. And So that's the number one thing you're looking for there. There are people in Alzheimer's disease who can have visual hallucinations. Parkinson's disease, it's quite common, even early, very early on in the disease course. But they're seeing motor symptoms. So typically in a case with Charles-Bonnet syndrome, you're seeing someone who's lost vision, and sometimes shortly after that, they start to have these hallucinations. It may just last, a few seconds, but they may occur, multiple times a day. But the person's not necessarily showing, memory loss, disorientation, and all the other things that you would typically see in a neurodegenerative disease.
Thank you, Dr. Silverstein. So we have one last question here. And also, if you do have any other questions that haven't been answered here, please feel free to reach out to the MHTTC and share those questions, and we'll try to get those answered. This question is, when seeing a blind or visual famous person on the air, TV comparisons are made, educating is not moving fast enough. Do you have any ideas to resolve or deal with continuous comparisons? And I believe this could be directed towards anyone, but it seems like Larry and Doretha.
Go ahead, Larry.
Okay. If I understand the question correctly, is that what is the comparison to celebrities on television that one see that are blind?
Yes, so I'm sorry, I think I read the first one incorrectly. When seeing a blind or visually impaired famous person on the air, comparisons are made. So do you have any ideas of how to resolve or deal with continuous comparisons, and those images or examples being ones that are really prominent in people's minds, and then there are comparisons that are made?
In terms of comparisons, I can't really think of any that I've seen. Well, there's one movie I think I saw where, well, I listened to it, whereas an individual who was blind and they was given the opportunity to have their vision restored, and then when they had their vision restored, they became a totally different person, and not in a positive way, in a more negative way. So I think, social media or media sometimes can distort how one may be, or I know for some people who have lost their vision, if they had the opportunity to have it restored, some people say no, they would not like to have it restored, because one, they've already adjusted to how things are being visually impaired or blind. And then seeing other types of movies that may have celebrities in them, or that are either playing blind or blind, I think sometimes it can be helpful if they are portrayed correctly, the same way as those that are portrayed, individuals that are portrayed as being deaf. If the portrayal is pretty accurate, I think it can be helpful, but if not, I think it can be a detriment.
I agree. I think there, unfortunately, there aren't very many realistic depictions on TV shows or movies of what it's like.
Doretha, did you want to respond to this question? Just giving you a chance before we wrap up.
I agree with Dr. Steve and Larry. I think it'd be, if we predict a person is blind, vision impaired, realistic, and not, I think it'd be very beneficial and helpful. Sometimes we distort what it really is. We more stereotype or stigma, and not really showing the true picture of somebody blind, vision impaired. So if we portray it in that way in social media, it could be very valuable for those who are blind, vision impaired, and those who are not, so they can understand and grasp more about being blind, vision impaired. It's just we had to do things differently, but there's still productive life after vision loss. So just portraying that, and the realistic of somebody blind, vision impaired can be very helpful to educate all of us.
Thanks so much, Doretha. And thank you everyone for your questions. I'm sorry if we didn't get to all of your questions. Please, again, feel free to share those with the MHTTC. I'm going to turn things over again to Kati. Thank you, Dr. Silverstein, Larry Woodard, and Doretha Smith for joining us today. And Kati, I'll turn things over to you to close things out.
Wonderful. Thank you again. Thank you, Dr. Silverstein, Larry, and Doretha. And thank you, Alicia, for helping us with the Q&A portion. Definitely a lot of questions. We are, I have kept track of all of the questions, and I promise to follow up in a follow-up email. And next slide, please. We also want to let you know that the Northeastern Caribbean Mental Health Technology Transfer Center is currently conducting a research study to increase our collective understanding of the experience, knowledge, attitudes, and perceived needs of the mental health providers in delivering services and supports to individuals who are blind or visually impaired. In the chat box, I shared the link to this survey, and you can also access this survey by scanning the QR code that you see on the screen, and in the follow-up email containing the links to our recording and the slides, I will also share the link to this survey. Next slide, please. We also want to let you know that we have a podcast available for you and you can find it on Spotify, Apple Music, Podbean, and it's titled Toward Wellness and Recovery. We have 2 seasons available, and we invite you to check it out. So next slide, please. Again, if you missed any other previous webinars that we have offered in the past, you may access them by scanning the QR code that you see on your screen. It's in our products and resources catalog that is listed on our website. Next slide, please. As mentioned before, we will have everything available to you within 7 days, including a certificate of completion that you are able to download that will be issued to you to the email that you registered today, as well as a link to the slides and the recording of this webinar. Next. We also invite you to follow us on social media at Northeastern Caribbean MHTTC. We have a Facebook, Twitter, and LinkedIn page, so you can stay up to date with any of our upcoming events and training programs. Again, I want to thank everyone for joining us today. And we hope that you have found all of this information useful in your work. And if you have any questions for us, please feel free to contact us. And again, we hope that you have a wonderful rest of your day. Be well.
Thank you.